Hey, I reckon today's a pretty good day to start learning about pneumocephalus. Now if we break it down, pneumo is to do with air and the cephalic part is to do with the brain. So we've got pneumocephalus. Let's get into it. Our physicians in previous centuries didn't have much of an issue working out what was going on. The first finding of pneumocephalus was in an autopsy report, amazingly in 1884. Lacker went on in 1913 to be the first to recognise intracranial air by radiological means. A small collection of intracranial air can be generally absorbed by the body. When the volume becomes too great though, pneumocephalus has resulted, and that's a rare condition. Pneumocephalus can be epidural or subdural, subarachnoid, parenchymal or intraventricular, depending where the air is located. Causes of pneumocephalus: usually head and facial trauma, skull base fractures and dural tears, and when a fistula results between the dura and the skull base, CSF rhinorrhea results, and sometimes air can take the place of leaked CSF on the brain surface and lateral ventricles. Tumours of the skull base can also be a causative factor. And then there are rare causes in the literature, such as pneumocephalus developing from rapid rhino insertion to achieve epistaxis, and severe otitis media. Tension pneumocephalus is actually a medical emergency. This is when more than just a little bit of air has found its way inside the cranial cavity. Now these frontal lobes become compressed and the interhemispheric space widens between the tips of the lobes. On a CT scan, it has the radiological finding dubbed the Mount Fuji sign, which is pretty obvious why. There's a terrifying part about this phenomenon because a ball valve mechanism causes one-way entry of air into the subdural space, no way for it to escape. More air enters through the defect when forced under pressure, like sneezing and coughing, the Valsalva manoeuvre, and there isn't enough pressure for it to passively leak out. This negative intracranial pressure that results as the CSF drains out causes air bubbles to travel to the space where the fluid has drained from. For example, if you invert a bottle of soft drink, as the fluid escapes, air bubbles to the top of the bottle. Same principle. These patients exhibit the normal signs of pneumocephalus. However, their restlessness is more severe, their conscious level declines progressively, they experience focal neurological deficits, and if left untreated, they can actually suffer from cardiac arrest. Now, tension pneumocephalus, while quite rare, should always be considered when any medical intervention has breached the cranial or spinal dura, even including endoscopic sinus surgery. Remember, it's a medical emergency. There are some pretty general symptoms of pneumocephalus. These include headache, motor weakness, seizures, focal neurologic deficits, and increasing sedation scores, and these certainly pose a big problem for nurses when we're monitoring neurological function post-cerebral surgery. Okay, so how do we actually treat these patients now? Well, from a surgical perspective, treatment can include craniotomy, burr holes, needle aspiration, insertion of an external ventricular drain, or a subdural drain with an underwater seal. It really depends what the patient needs. From a conservative standpoint, the use of supplemental oxygen has been shown to decrease the size of pneumocephalus. In patients, the amount of oxygen and the mode of delivery is under contention in literature. But generally, the use of a Hudson mask at a minimum is considered acceptable. From a nursing standpoint, in addition to the supplemental oxygen, nursing the patient in an upright position or a semi-Fowler position of at least 30 degrees, and avoiding any manoeuvres which may increase intracranial pressure, like straining, sneezing, nose blowing, are all crucial. In terms of future management, there's a lot of research being currently conducted, but one study looked at nasopharyngeal airways to prevent tension pneumocephalus. 120 people were fitted with a tube for 3 days. There were no adverse events, and tension pneumocephalus only happened in 3 patients. I think the take-home message here today is that full recovery is definitely achievable if diagnosis and intervention is swift. Time's really our enemy here. Thank you for listening.
created using Powtoon.